I'd like to also thank Nancy Fishbein, who is one of my colleagues at Stanford University. She and I worked on this talk together some months ago, so I need to call her out. So what we're going to talk about today is the anatomy of and pathology of the head and neck. That is below the skull base, and but above the thoracic inlet. And we can think of this as a group of fascial spaces shown here on this slide, where you can understand anatomy and pathology as it arises in these spaces. For instance, mucosal space, the parapharyngeal space shown here in red, the masticator space around the mandible, the parotid gland, we call that the parotid space. Its deep portion abuts the parapharyngeal space. Remember, the seventh nerve courses through it. The carotid space around the jugular and carotid artery and the cranial nerves. The potential retropharyngeal space, which can be involved in infections and other pathology of the pharynx. And the paravertebral space around the bones, which can sometimes bulge into the head and neck. And so you see some anatomy on the left side of this screen and the spaces on the right. So let's talk first about the pharyngeal mucosal space. So this is the mucosa that hangs from the skull base down. Of course, it's how we breathe through the nose and swallow, etc. And it's consisting of, up in the nasopharynx, a thin, high signal intensity rim on MR scanning. You won't see this on CT scanning. And its major contents include this squamous mucosa. It has some lymphoid tissue, minor salivary glands, and is surrounded by the pharyngeal constrictor muscles, shown here on MR scan, right here as a dark signal. And some of the common pathologies, of course, are inflammatory disease such as tonsillitis and tonsillar abscess. And of course, cancer. Squamous carcinoma occurs in the nasopharynx, usually in the fossa Rosenmuller, right in this little crevice. Lymphoma can involve the nasopharynx and upper aerodigestive tract. And one can have tumors of the minor salivary glands that line the aerodigestive tract. And we'll discuss squamous cancer later in the session. But here is an example just to show you a very early nasopharyngeal carcinoma. You notice there's a little mass in the fossa of Rosenmuller, which then subsequently gets much larger. And you can see that there's some fullness on CT, but you don't have this superb anatomy that we see on MR. So this is a T2-weighted MR scan, and this is a CT scan. So you have to be careful on CT not to overlook these subtle masses that may occur in the nasopharynx early on. On the other hand, you may overcall some of these lesions because some of these areas can be asymmetric. So you have to be a little careful, and if there are concerns, this is where an MR scan is very useful. Okay, so here's the parapharyngeal space on an MRI scan, and you'd see it dark as fat on a CT scan. And this is the central space of the deep face. This is the area that we will use as a landmark. It will be pushed by the other spaces, the other masses in other spaces. It contains fat. The branches of the third trigeminal nerve are coursing through this area, the internal maxillary artery and pharyngeal plexus. And we can see some pathology here. For instance, infections can course up and down through the parapharyngeal space. One can see minor salivary gland tumors that arise from rests that are in the parapharyngeal space. Lipomas, of course, because there's fat here. And occasionally benign lesions such as atypical branchial cleft cysts, a second branchial cleft cyst. And of course, you'll notice that the parotid gland abuts this, the deep portion, and a mass here will push this medially as well and look like a parapharyngeal space mass. So here's just a couple examples. On your left, you see an atypical second branchial cleft cyst. It's called atypical because most branchial cleft cysts occur down near the mandible. But remember that the branchial apparatus courses up through the branchial cleft anomaly, courses up to the pharynx into the tonsil, and a cyst can occur there as well. And on the right side of your screen, you see a large pleomorphic adenoma of the deep lobe of the parotid gland billowing into the parapharyngeal space, deviating it medially. So you see this little fat shows you that this is a mass pushing the parapharyngeal space medially. You'll notice that the carotid and jugular are pushed posteriorly, and this tells us that this is not a carotid space mass, but rather a deep lobe parotid mass. Okay, just a word about branchial cleft anomalies. Remember that these arise from abnormalities in the branchial arches, the pharyngeal arches, and the cervical sinus. And the second branchial cleft is the one that has most of the anomalies, although they can occur in any of these pharyngeal grooves. It can arise in the first, second, third, and fourth, but most arise in the second. And these anomalies can result more frequently in a cyst, but one can have a sinus tract or a fistula between the pharynx and the outer portion of the skin. These are most commonly seen in the second to fourth decades of life, whereas sinus and fistulas almost always present in infancy. And of course, we like to take these out because they can lead to infection, and that can lead to a catastrophe for the patient. So here's a little cartoon showing you how the tonsil, which is shown here, the palatine tonsil, is the source of the upper part of the branchial cleft anomaly. Here is a little fistula that is coursing down through the carotid bifurcation out towards the skin surface, usually anteriorly near the sternocleidomastoid muscle. And anywhere along this tract, one can have a cyst, or one can just have a small fistula out to the opening, or a sinus tract as well into the tonsillar sinus. So these things can arise in different locations as well. You can have a third or a fourth branchial cleft cyst as well. So here's the typical second branchial cleft cyst, an enlarging mass in a 16-year-old female. You can see a little lump in her neck. And here's the CT scan. And what you notice, and this is very important in differentiating cancer, a lymph node metastasis, is you see there's no septations, there's absolutely no rim to this cyst, and it's interposed between the sternocleidomastoid muscle here in the neck and the submandibular gland. So this is a classic second branchial cleft cyst in the right location. Now, you'd want to look around for other nodal masses. You'd want to look around for any nodules in the wall or septations, and that would alert you that this is not a branchial cleft cyst, but could be a cystic metastasis. Okay, so here's an example of a Fistula Graham. This was a young man following who had a little draining sinus in the anterior portion of his neck, and I'm injecting that just to show that this is a tract that goes all the way up, and he tasted contrast, so it went up to his pharynx. And here's the CT scan following the procedure, and you can see there's contrast in this sagittal reformatted image just in front of the sternocleidomastoid muscle. And here its location in the cross section, just in front of the sternocleidomastoid, coming up near the pharyngeal tonsil and draining into it. So this is a branchial cleft anomaly, along which anywhere along that course can arise a cyst, and the second branchial cleft cyst occurs most commonly here. And they have to take this out, and here's a little surgical anatomy for you. This is the branchial anomaly being taken out into separate things from the neck. Okay, parapharyngeal space. Back to the parapharyngeal space masses. When we see a mass like this on an MR scan, T2 weighted, T1 weighted after contrast, you see there's partial enhancement, there's a cyst. This is pushing into the parapharyngeal space. The differential diagnosis here should include a benign mixed cell tumor of the parotid and or cell rests of minor salivary gland tissue. It could be a schwannoma of the third division of the trigeminal nerve or branches thereof. And this was a schwannoma, so that's the differential. Sometimes we can see other very odd things there, but when you see a mass like this pushing the parapharyngeal space medially, those are the two primary differentials. Here's an unusual case that we saw. This is a cyst that's arising from the minor salivary glands in the sublingual space, a so-called ranula. And a ranula is nothing more than a pseudocyst ruptured with saliva that is developing a mass. And you can see this one courses up into the parapharyngeal space right here. This is a cystic mass coursing down into the sublingual salivary gland space. So it can very rarely be a source of ascending infection from the submandibular gland and other aerodigestive tract infections. So the cystic mass, in this case, involuted on its own, but here you can see it coursing up through the parapharyngeal space. So there's a communication like an elevator shaft from the floor of the mouth all the way up the parapharyngeal space to the upper pharynx. Let's talk about the masticator space. This is a large space surrounded by fascia. It includes what we sometimes term the infratemporal fossa, and it's equivalent essentially to the nasopharyngeal masticator space. So you can see that it's anterior and somewhat lateral to the parapharyngeal space, surrounding the mandible. This is a T1weighted MR scan. And it contains the muscles of mastication, so the masseter muscle, the medial and lateral pterygoid muscles, the temporalis muscle. Here you see a small slip of the temporalis muscle. Here's the lateral medial pterygoid muscle coursing down towards the angle of the mandible. And of course, the mandible and teeth itself. So what do we see here? From a benign standpoint, you can sometimes see asymmetry of the masticator space muscles based on just on normal anatomy. Sometimes the muscles are bigger on one side than the other. One can sometimes see a little slip of parotid tissue along the surface of the masseter muscle. This is the accessory parotid gland, and we'll talk a little bit about that later. One can see benign lymphatic or veno-lymphatic malformations. Abscesses, of course, from the teeth. You might see this frequently, actually, in this area. One can see nerve sheath tumors because there is branches of the nerves down to the teeth, the alveolar nerve. Sarcoma, such as rhabdomyosarcoma, and of course, extension of squamous carcinoma. So a lot of things can involve the masticator space and give rise to pain when you open or close your mouth, okay? So here it is in the coronal plane. You can see it extends all the way up along the temporalis muscle, along the side of the calvarium. So this is the temporalis muscle coming down, the masseter, the medial pterygoid muscle, and the lateral pterygoid muscles surrounding the mandible. And all of this can be involved in an infection. It can come all the way up here, as well as tumor. Tumor can break out of this fascial layer and extend into the upper nasopharynx and cavernous sinus. So let's look at a couple examples. This is a rhabdomyosarcoma, very large sarcoma in a young person, 11-year-old with a deep facial mass, and you can see that it's surrounding and abutting the mandible, and it's homogeneous, almost doesn't, there's not a lot of edema around it. So one might also look at this and say, geez, could this be some sort of benign tumor? But you can see it rapidly, it can increase in size, and it can look rather benign, but this is a rhabdomyosarcoma. Notice it's pushing the parapharyngeal space musculature medially and the parapharyngeal space medially. Here is a deep space odontogenic infection surrounding the mandible. This person had a tooth that was pulled and developed infection, and you can see little islands of abscess involving both sides of the mandible. This is the masticator space. It's surrounded by a deep fascial layer, and it will contain that infection, but the infection can rise and go superiorly along the calvarium. Here's another one on the other side, post-dental extraction, complaining of right neck pain. And here you see the infection right here and a bit of masticator space muscle edema. Here is a veno-lymphatic malformation, and one that is a little more extensive. And both of these can involve, and often do, the masticator space. They can course through the muscles in the case of a transspatial venous lymphatic malformation, or they can be isolated, as you see here, with small phlebolysis. This is on MR, very close to the masseter muscle. And this is a very common place for veno-lymphatic or venous malformations. Okay, and here's a venous malformation in the upper masticator space along the temporalis muscle. Very common. And these things enhance slowly. They may show a little enhancement that increases over time. And if you see phlebolysis within the venous malformation, you can be assured that that is the diagnosis. And here are some calcifications or phlebolysis within that structure. Now, here's a rare masticator space mass. It's an odd disease called Keramas disease, and this involves the subcutaneous tissues as well as some of the muscles of the masticator space. It has a predilection for East Asian males, and what it consists of is follicular hyperplasia and infiltrates of eosinophils and post-capillary venules. It's a very odd sort of post-inflammatory mass that is sometimes chronic but benign, and one can see a mass like this. You'd wonder about lymphoma in this case, of course, or a sarcoma, but this is what it looks like on MR. It's sort of poorly defined, slightly high in signal on MR and low in signal on T1 weighted image mass. Not involving the mandible, and this would be a diagnosis of exclusion. You'd have to biopsy this and make the diagnosis of Keramas disease. Now let me just briefly talk about the third division of the trigeminal nerve, which you can always find if you find the sella turcica, where the pituitary is. Just on either side, you'll see a little hole on the skull base right here, and this is the opening for the third division of the trigeminal nerve. And the importance here is that tumors of the head and neck, particularly of the masticator space, can spread proximally along the mandibular division of the trigeminal nerve and course into the cavernous sinus. And these patients will usually give rise, they usually have pain or numbness of the ipsilateral chin, or dysfunction of the muscles of mastication, because this portion of the nerve supplies the infraalveolar nerve, which will, in addition to innervating the teeth, may innervate the chin. So the numb chin syndrome can give rise to, or should be an alert that you may be dealing with tumors along the trigeminal nerve. And it exits the cranium via the foramen ovale, which is this structure right here, and immediately enters the nasopharyngeal masticator space. So here is V3 coming down. Notice it's medial to the lateral pterygoid and will course along the parapharyngeal space to branch into the masticator space, including the alveolar nerves, and it innervates the pterygoid muscles. So if there's a problem with V3, you will see atrophy of those muscles. Okay, so here's an example of a patient who had melanoma of the lip and now had progressive chin numbness and difficulty chewing. And right here you see an enlargement of the inferior alveolar canal. This is the foramen on either side of the mandible through which the inferior alveolar nerve courses. And you can see that this is expanded on the left side, and it grows all the way up into the cavernous sinus. And here we see abnormal enhancement. Notice on the right side a normal size V3 with a little bit of enhancement around it, which is normal. This side on the left is very abnormal, and you can see the masticator muscles are atrophied because this tumor is involving the innervation of the muscles via V3. Here's just another example of squamous carcinoma of the face, and this patient who had a prior stroke has atrophy of the muscles of mastication on the left. You can see that very clearly on CT or MR, in this case a T2-weighted MR. And when we see this, we look carefully and we find that there's squamous cancer that has been growing along the V3 branch of the trigeminal nerve. Patient presented with numbness of the lower face and some difficulty chewing because of muscles of mastication. So perineural spread of squamous cancer or of melanoma can give rise to these appearances. Okay, let's move from the masticator space now posteriorly to the parotid gland. And the parotid gland, of course, is surrounded by a fascial plane. It contains the external branches of the artery, external carotid artery, retromandibular vein, and remember the facial nerve will be coursing through and ramifying into the parotid gland. Okay, and they also contain lymph nodes, and small little lymph nodes can occur within the parotid gland, giving rise to a number of things such as lymphoma, reactive lymphadenopathy, lymphoepithelial cysts in the case of HIV. Now, they don't really have lobes, the parotid gland. We often term the superficial and deep lobe, but it really is a portion of the parotid gland intersected by the facial nerve, which is coursing from the skull base, temporal bone, in an angle through the parotid gland. So we sometimes refer to the deep lobe, but that's just deep to the facial nerve, superficial to the facial nerve, and the bottom is the tail. Okay. So I mentioned the accessory parotid tissue that is coursing along Stenson's duct and can be a source of tumors and other infections. And also the patient may feel a little nodule here, and it's nothing more asymmetrically, and it's nothing more than accessory parotid tissue. Stenson's duct is draining this way and coursing then into the mouth around the masticator space. Now, what kind of pathology do we see in the parotid space? We see in children, one of the most common sites of tumors is the parotid gland, and this is a benign lesion, very large. It looks like a just gigantic parotid gland, and this is a hemangioma, the most common tumor of this area in children. But one can also see, as I mentioned, lymphoepithelial cysts. The tumors that arise from the parotid gland are most often benign, pleomorphic adenoma being the most common, a Warthin's tumor, often bilateral, and of course we can see malignant tumors such as adenoid cystic carcinoma, adenocarcinoma, mucoepidermoid carcinoma, and lymphoma and metastasis from the skin surface going to these nodes into the parotid gland. So a number of different pathologies. This happens to be a hemangioma, a little 4-month-old with a left neck mass. Okay, here's your classic mass that you see in a parotid gland. You see that it's located just posterior to the retromandibular vein and external carotid artery, which are being pushed anteriorly. The facial nerve would be probably coursing around this. You can't really see it very well, but just by its position, it could be this way or it could be that way. It's probably rising deep to it, and that would be an important thing to try and find out, because the surgeon in taking this out will have to skeletonize the facial nerve and try to remove this if it's deep to the facial nerve. But you'll notice that it's low in signal on T1, very, very bright on T2. That tells us that this is a watery tumor and most likely benign, and it enhances, and it can enhance slowly like a venous malformation, initially enhancing and then gradually filling in. Classic pleomorphic adenoma, also known as a benign mixed cell tumor. The same terms apply to the same lesion, benign mixed cell tumor. These can be multiple along the course of the parotid gland, but most commonly present as a solid tumor like this. Now, could this be a lymph node? Sometimes when this is smaller, it can look like a lymph node, and that can be a problem, but usually when they're this big, they're not a lymph node, and you look around for other lymph nodes and you're seeing none, most likely. Now, what we would do before we took this out is that we would probably do a CT-guided biopsy or an ultrasound-guided biopsy, seeing this, and we don't have to worry about the facial nerve. It's not going to be damaged. We put a needle in that and have our cytologist in the room and do a fine needle aspiration for pleomorphic adenoma. Okay, so these are 80% of the parotid masses. They can occasionally turn malignant, in which case they're termed carcinoma X pleomorphic adenoma. They can recur in a good 1 to 5% of patients and occasionally be multicentric, but normally not. Okay, here is another one in the deep lobe. You can see it looks very similar, well circumscribed, high signal, benign pleomorphic adenoma located right here in the deep lobe of the parotid gland. Differential diagnosis, maybe a schwannoma, it's hard to say, but this is most likely a pleomorphic adenoma. And again, how would I biopsy this? Well, I don't want to hit the artery. I might come right behind the mandible under CT, or I might come like this, or one could even come this way with a needle under CT guidance and biopsy this. There it is after contrast, and you can see it has homogeneous, in this case, contrast enhancement. Now here's a giant one. This poor guy, he has a huge, huge lesion in his parotid gland and masticator space area. It's got blood in it, it's got septations, it's gigantic, and it enhances. And when they get this big, you know, it's a little hard to know what it is. In this case, this was a giant pleomorphic adenoma. He had this mass for years, didn't take care of it, and it also had a little cancer in situ. So this was a complicated case, but it can get very large if not taken care of. Okay, we're going to talk a bit about the facial nerve because we just mentioned its course through the parotid gland, and here's a nice anatomic picture of it coming out of the stylomastoid foramen, and you can see it ramifies into multiple branches in and about the parotid gland, coursing to the masticator space, as I mentioned before. It arises in the floor of the medulla and pontomedullary junction from several nuclei. Here's the motor nucleus of the facial nerve. We're looking here at a cross section. This is the fourth ventricle, and a little hump in the floor of the fourth ventricle is the facial colliculus, and it's called that because the facial nerve courses and loops around the sixth cranial nucleus and then courses out of the pontomedullary junction to course to the temporal bone, where it then comes into the temporal bone and courses laterally just beneath the lateral semicircular canal towards its stylomastoid foramen. On the way, giving off some branches or collecting some branches, the chorda tympani, which is a branch of the fifth cranial nerve, courses along this structure, and also the greater and lesser petrosal nerves coursing towards the pterygopalatine and otic ganglion in the nasopharynx area. So it's a complicated nerve, it's a complicated course in the temporal bone, and then as it exits, it courses through the parotid gland. So when you have a facial palsy, you have to scan from all these ramifications in the face all the way back to the nucleus in order to make sure that you haven't missed pathology. Here's the course of the facial nerve on CT. We're looking at cross-sectional CT anatomy here. This is the internal auditory canal. This is the vestibule and a little bit of the cochlea. And above the cochlea, you see this little canal. This is the anterior genu of the facial nerve giving off the superficial petrosal nerve. And then the horizontal portion of the facial nerve coming down and then coursing now into the plane of the section down towards the stylomastoid foramen. On the coronal plane, we see that coursing out into the parotid tissue. And here it is just in cross-section below the lateral semicircular canal. So what can involve the facial nerve besides tumors of the parotid gland, which can hop back on the facial nerve and course back into the temporal bone? Well, here's an example of acute facial palsy in a patient otherwise normal. And this usually rises very suddenly and then gets better over the course of several weeks. And this is an infection, probably from either a herpes virus or some other virus that causes inflammation of the facial nerve, constricting it right above the cochlea. This is an axial postgad T1weighted MR scan. And this is Bell's palsy. 50 to 80% of facial palsies. The classic presentation is in a sudden, acute, spontaneous facial palsy recovering within several weeks to months. Atypical facial palsy, that is one that starts in portions of the face, or slowly progressive, slow to resolve, recurrent, means that you've got to image. Normally we don't image in Bell's palsy. If there are other neurologic symptoms, and there you're looking for perineural spread of tumor. So here's an example of a patient with atypical Bell's palsy. He had a former parotid resection for carcinoma expliomorphic, and now presents with new progressive right facial palsy. And indeed, when we scan with a coronal MR, we see abnormal enhancement coursing up along the facial nerve just above the cochlea, all the way back into the temporal bone. Here it is enlarged on the left and normal on the right. So we have to look very, very carefully. Here's an example of a patient presenting with facial palsy. And we look at this and we say, geez, it looks pretty normal. Maybe the parotid is normal on the right and a little bright on the left, but we don't really see anything. And that's because cancers can look very, very subtly similar to the parotid tissue on a T2-weighted image, as opposed to benign tumors. But when we look at our CT, or in this case a T1-weighted MR, we see around the normal parotid tissue, which is atrophic, a mass coming in through the parotid gland right here. And this is tumor spreading retrograde along the facial nerve up towards the stylomastoid foramen, which is located just medial to the tip of the mastoid. This is the facial nerve surrounded by fat, and it's being infiltrated by this tumor. Cancer of the parotid gland. Okay, that's the parotid gland. The carotid space we see behind the parotid tissue, and that includes the internal carotid artery, jugular vein, the cranial nerves 9, 10, 11, and 12 at the nasopharynx level, and 10 only at the oropharyngeal level and infrahyoid level. And remember, there's a sympathetic plexus also surrounding and nearby the carotid sheath. So what can we see here? Well, of course, vascular lesions such as aneurysms. We can see lymph node abscesses. Most importantly, paraganglioma and nerve sheath tumors. This is the main differential of a mass in this location, paraganglioma and nerve sheath tumor. And then, of course, extension of squamous carcinoma can occur here as well. And masses here will push the carotid and jugular forward. So here's an example of a mass on MR scanning, and you can see the carotid artery and jugular vein are separated. They're pushed by a patient who has a family history of paragangliomas, had a prior removal of a glomus tumor, and now has a paraganglioma of the glomus area, glomus vagale. So classic mass in that location. And you notice it's different than the deep lobe of the parotid, because the carotid arteries aren't pushed back by the deep lobe, but actually pushed forward by the mass in the carotid space. Here's a CT scan of another patient. And you'll notice that likewise, the parotid abuts this, but is this a parotid tumor or a carotid space? Well, look at this. This is pushed forward. This is the carotid artery pushed forward by this mass. And this, therefore, is a carotid space mass. Paraganglioma usually enhances intensely. Schwannoma sometimes does. This is most likely a schwannoma because it's not intensely enhancing. That is arising from a branch of the 12th cranial nerve. And how do we know it's coming from the 12th cranial nerve? Well, look down in the floor of the mouth and you can see on that side there's atrophy and fatty infiltration of the muscles of the floor of the mouth innervated by the 12th cranial nerve. So this is a mass that is causing 12th cranial nerve palsy. And you'll notice that 12th cranial nerve palsy, sometimes the tumor, or rather the tongue, because of its atrophy, will fall back when the patient is in the supine position, almost looking like a mass lesion. Okay, the retropharyngeal space. This is a potential space from the skull base to the upper mediastinum. It contains fat and some lymph nodes, not usually below the hyoid bone, and one can therefore see adenopathy, most commonly abscesses from tonsillitis, a lipoma rarely, and occasionally invasion by squamous carcinoma. So here's a 9-month-old, 1 week of symptoms, intermittent fevers, poor intake. You see on a lateral film displacement of the aerodigestive tract by a retropharyngeal mass. We don't know from what it's come. This would be an indication for a CT scan for sure. She developed a lump below and behind her right ear and neck swelling after two doses of oral antibiotics. And here we see an extensive mass with extensive adenopathy behind the pharynx. This is a retropharyngeal mass, and you can see that it extends all the way down into the oropharynx. It has peripheral enhancement. This is an MR scan, and you can see this retropharyngeal abscess is extending all the way down into the upper mediastinum. So retropharyngeal infections are really very, very dangerous because of that potential to spread inferiorly into the upper mediastinum. A terrible situation with terrible consequences for the patient unless the patient is treated. So this is what we're talking about. The retropharyngeal space can come down all the way to the T4 or 5 level because of its surrounding fascial layer. And it can even go into the mediastinum if it courses, as with this diabetic patient, through the retropharyngeal space into the upper mediastinum, leading to terrible consequences for the patient. So this is very important to recognize and to treat effectively, either surgically or with antibiotics or both. Okay, the perivertebral space. This is a space surrounding the osseous structures of the spine and paraspinous musculature. And the reason this is important is that besides containing the vertebral artery and vein and bodies and the prevertebral muscles, that pseudomasses can occur here. Osteomyelitis and abscesses can occur from the bones, pushing forward the retropharyngeal space. So you want to make that distinction. Can have primary nerve sheath tumors, chordomas, mets to the vertebral bodies. And let's look at a couple examples. So here we have a very large destructive mass involving the C1 vertebral body, and you can see it's pushing forward the prevertebral muscles and the retropharyngeal space. And this happens to be a plasmacytoma with extensive destruction, patient with myeloma. But the point is that you can see it's pushing forward the carotid space, the parapharyngeal space, the retropharyngeal space. This is a prevertebral muscle and a bone lesion. Here's another example of a patient. This one, a spine lesion, increasing neck pain, no fever, normal white count. The differential diagnosis would be osteomyelitis or some other possibly a tumor. You can see there's some extension into the retropharyngeal area, but this is the prevertebral space, not the retropharyngeal space. It's pushing forward, and this happens to be a patient with an unusual fungus that we see here in California called cocci. We're seeing a great deal of cocci, coccidiomycosis. I don't know if you see this in Africa, but we see it here in California. It's a fungus that grows in the soil in the middle portion of California, and because of the droughts that we've had and then the subsequent rains, we've seen a huge number of these patients now coming in with systemic cocci, and it looks almost like TB or a tumor treated with antifungal antibiotics. Now, I've mentioned all these various spaces, and sometimes lesions don't respect spaces, and we call these transspatial masses. And this can occur because of lesions that go through all the spaces, such as lymphangioma or neurofibroma that course along the nerves, that course through various spaces. We can see this sometimes with vascular lesions, vascular malformations and hemangiomas, and very aggressive infections and neoplasms. So this is a partial list of so-called transspatial masses. Here's a mass that's going into the prevertebral muscles, coursing along the subcutaneous tissues, pushing forward into the retropharyngeal space. So an example of a transspatial mass. Okay, so that is sort of the idea behind transspatial masses. Now, the infrahyoid neck, we've been talking mainly about the spaces of the upper neck. The infrahyoid neck has a number of spaces as well. The visceral space surrounding the thyroid and these structures, the carotid, retropharyngeal, etc. spaces. And so it's a little bit different, but these spaces can be used in the same way as I've been talking about. That is a mass around the thyroid gland we think of as the visceral space. Now, when we're talking about the oral cavity and the hypopharynx and larynx, we want to remember the traditional subdivisions. We've been talking about spaces, but the nasopharynx is everything above the level of the palate into this area. The oropharynx is the palate down to the level of the epiglottis. This then is the oral cavity anteriorly. The posterior third is part of the oropharynx. And then the hypopharynx is from the epiglottis down through the piriform sinuses, the postcricoid area, and then we get into the larynx. So there's subdivisions that we talk about. So nasopharynx, you can see CT, fossa Rosenmuller, beautifully shown here, prevertebral muscles on MR, the mucosa beautifully shown. Nasopharyngeal carcinoma, we'll look for expansion of the fossa Rosenmuller, retropharyngeal nodes, and nodes in the second division of the level 2 lymph nodes of the neck. Another example, squamous carcinoma of the nasopharynx, early nasopharyngeal carcinoma. In the oropharynx now, this is at the level of the palatine tonsils, the uvula. The normal structures of the tongue are seen on MR. And here's a mass of the base of tongue, the oropharynx, presenting as a large mass. We would call this an upper oropharyngeal or lower oropharyngeal or upper hypopharyngeal mass. And this can sometimes be confused with asymmetric normal lingual tonsils, which we see here, compared to this tumor on the right, base of tongue, part of the oropharynx. Very common squamous cancer of the tonsil on a T2-weighted MR invades the tongue, invades laterally the muscles of mastication, causing trismus, may give rise to a level 2 lymph node, which you see here, classic palatine tonsil carcinoma. Another one extending into the skull, into the base of tongue, and you can see it's coursing down towards the larynx. Very serious tumor, presenting also with level 2 lymphadenopathy, etc. So the oral cavity extension up through the parapharyngeal space and these structures that we see here, the submandibular and sublingual space, very classic. So here's the mucosa. Here's another squamous carcinoma of the tongue. I want to just then end with the sublingual space and the submandibular space. The sublingual space contains sublingual salivary glands. I showed you at the outset a ranula. The deep portion of the submandibular gland, of course, is here, and it's this structure we're talking about right here and right here. The lingual nerves, the cranial nerves 9 and 12, and the anterior extension of the hypoglossal muscle. So tumors of this area, this is an adenoid cystic carcinoma arising from the sublingual salivary gland located here normally on the left, can rarely give rise to tumors. One can see a simple or diving ranula, inflammation, or invasion with squamous cancer. Submandibular gland. Around the submandibular gland, the contacts include the gland itself, the anterior belly of the digastric muscle, lymph nodes, facial arteries and veins, and some of the portion of the 12th cranial nerve. And it has a relationship, as I showed you, to the parapharyngeal space, such that pathology here can course up through the parapharyngeal space. So you can see ranulas, lymphangiomas here, all kinds of things, ductal obstruction from salivary calculi, neoplasms, as well as nodes. And so what you may see here is an abnormal enhancement of the submandibular gland, normal on the right, abnormal on the left, surrounded by lymph nodes. This is an enlarging submandibular gland with probable lymph node metastases, very concerning for a cancer. A fine needle showed mucoepidermoid carcinoma. However, this cystic mass surrounding in the sublingual and submandibular space on both sides of the mandible is most likely benign. There's not a lot of infection, cellulitis around this. This is most likely a ranula, which, as I mentioned before, is like a pseudocyst caused by an obstructed duct of the sublingual salivary gland or submandibular salivary gland, and then saliva courses through the various spaces. So that's a diving ranula. Here's just another example of another mass, a cystic mass. This is an infected branchial cleft cyst that's extending down towards the submandibular space. So a lot of things can occur in that area. And finally, in the hypopharynx, this is an area just above the larynx where we can see primarily cancers involving the piriform sinus, the pharyngeal walls, or the so-called postcricoid space. And this is an area that is right above the esophagus and larynx, but below the oropharynx. And we'll normally see cancers arising in this. Here's a patient with a cancer of the piriform sinus with lymph node metastasis, a hypopharyngeal carcinoma. I don't think I'll go into the larynx right now, but let me just end by saying that understanding the spaces of the head and neck and the contents of that anatomy gives you a very powerful insight into the pathology that may be occurring there. And of course, we have a differential diagnosis. Sometimes we can make the diagnosis on imaging and suggest it. Other times we have to put a needle in it under ultrasound or CT guidance. And sometimes we just offer a differential diagnosis for the surgeon to go in and take care of things. The most important things I think we want to remember is, number one, that infection can be very devastating, and we don't want to miss that. We don't want to confuse a benign branchial cleft cyst with cystic metastasis, and so we'll look for septations within the cyst or nodules. And we want to also pay attention to perineural spread of tumor. When we find a tumor, think about the nerves that are in that area and watch them and carefully go back, and you won't miss those sorts of things because then the radiation oncologist or surgeon can deal with that appropriately. All right, so I think we better stop there, and I want to just thank you all for your attention